I feel very fortunate to be able to speak with you today. I come from, if you were part of the earlier sessions, one of the states that has all the bad things and very little of the good things in terms of disparities and equity. So my disclosures are that I've received funds from the NIH for grants and cooperative agreements in cervical screening and triage and HPV vaccination, all through my institution. And I've received reagents, equipment from Roche and from Hologic, Genera Biosystem, research support from Hologic and Becton Dickinson through the University of New Mexico, my institution, and personal fees from Becton Dickinson. So worldwide, we know that the recognition that human papillomaviruses cause virtually all cervical cancer has enabled the innovations of both HPV vaccination and HPV-based screening. Those of us that have made careers in this area, it was the most amazing journey for certain. Right now, we know that the World Health Organization has promulgated accelerating the elimination of cervical cancer as a global public health problem. And worldwide, there's been a commitment from over 194 countries to do this. Now, doing that is another story, as we all know. The WHO's global strategy for cervical cancer elimination was put forth by the Director General, and the goals were to achieve a threshold considered elimination of 4 cervical cancer cases per 100,000 women years. And the following targets were set for 2030. Vaccinate 90% of girls fully with HPV vaccine by the age of 15, screen 70% of women using a high performance test by the age of 35 and again at the age of 45, and treatment of 90% of women with precancer and 90% of women with invasive cancer. Probably worldwide, all of these are big challenges, but in the United States, we have challenges with reaching 90% vaccination. We have a gender neutral strategy. Generally, we achieve 70% screening coverage. And as you know, we screen a lot more frequently than twice in a lifetime. So the question is, can we, quote, eliminate cervical cancer within the next century? And will these targets be reached in the United States? So cervical cancer is a major health expenditure. We basically have this whole part of the population for screening, and we have vaccine targets for routine administration of 9 to 14-year-olds with the recommendation targeting 11 and 12-year-olds. We have additional vaccination for catch-up going from 13 to all the way up to 26 by recommendation of the ACIP and up to 45 years of age by approval of the FDA. Now, when you look at this, it is a population administration of a gender neutral vaccination because we're very wealthy and we can do this. The biggest bang for the buck outside of the United States in most countries is to target girls, and if they have enough resources, then to target boys. But you're talking that we're spending many tens of billions of dollars of healthcare to actually conquer HPV-related cancers, with the main target being cervix cancer. Sorry, I don't know the order of that one as it went in. In the US, cervical cancer, though, remains a failure to screen women, and to a lesser extent, a failure to follow up women with abnormalities. And both of these kinds of failures have been associated with inequities. The slide that is in inserted here is simply, you saw it maybe earlier, and that is for poverty. The distribution of poverty is very associated with cervix cancer. It's associated with racial and ethnic minorities, lower educational attainment, living in rural versus urban settings. I live in a state that is gigantic, and to go from one city to another, you can drive typically 3.5 to 5 hours. Lower levels of acculturation, including language barriers or spoken language at home. New Mexico is the second most common Spanish-speaking state behind Puerto Rico. Being uninsured or covered by public versus private or military insurance, not having a usual source of care or medical home, and older age. So there's a lot of inequities in this particular cancer. So I'm going to go over briefly what many of us or most of us already know, but historically it's important from the perspective of where are we putting our money and where should we go. So the focus of the last several decades has been on HPV-based technological innovations to improve both primary and secondary prevention. For primary prevention, as we've discussed, we have HPV vaccination, and it moved from licensure in 2006 as a 3-dose vaccine to a 2-dose vaccine. And now the NCI is studying a 1-dose strategy in Costa Rica. Other studies are ongoing as well to look at 1 dose. So with that being said, substantial research, industry, and healthcare dollars have been expended to overcome barriers of uptake of vaccine to achieve higher population coverage, but we may be coming to a plateau. So this slide shows data from the NIS survey from 2006 to 2020. And what you can see is that if you look at what we achieve with Tdap, so we achieve over 90% coverage, or with meningococcal vaccine, we have achieved the WHO goals for HPV. But if you look at what's happening with HPV vaccines, for greater than 1 dose, we achieve somewhere in around 75 to 77%. But if you look at being up to date, meaning having all the doses you need by the time that you have been, this survey is taken, we're at about 60%. So I have down here New Mexico, which for a state with a lot of equity issues, we do very well with a lot of effort on the ground for vaccination. We do well with many vaccines. But the question here is, will HPV vaccination exceed 70 to 75% without mandates, or will we fail? These vaccines, Tdap is mandated for school entry, and meningococcal vaccines have been mandated in various settings, with about half of the states having a variety of different mandates. And it really was those mandates that brought it up to 90%. But it is also important to point out that being vaccinated correlates in investigations that have been published with getting cervical screening. So as I hope to show you, cervical cancer is a disease of women who don't get screened, and will it become a disease of women who don't get vaccinated and don't get screened? This slide just shows you that vaccination coverage is variable by state, and this is associated again with inequities. This slide shows you the major reductions in HPV infection that have been observed despite lower vaccine coverage. we are very fortunate that HPV vaccines have high impact and they benefit by herd immunity. So this slide is taken from New Mexico, but reflects very much what has been seen in studies like NHANES, et cetera. This represents over 100,000 actual laboratory tests done in my lab. But if a woman had 100% risk in 1989 at 18 years of age, by 1996, the risk for all of the 4 types in the vaccine, 16 and 18, the cause of 50% or more of cervical cancer, 31 and 33 other bad players in cervical cancer, and HPV 6 and 11 had similarly decreased to below a 20% risk compared to what it had been, which is just spectacular. Also, there's an observation that has been published by our group and others. In the United States, we saw a drop in high-grade pap smears by about 50% and a drop in cervical intraepithelial neoplasia grade 2 for girls 21 to 25 or women. And the age is creeping up over time. Now, this was, the endpoint of this is 2017, but that is dropping even more since then. So this is a slide that we published to basically look at surveillance that's going on in many countries, including the United States, but I'm showing it to you to talk about a few things. One is that cervical cancer prevention is made up of 3 pillars. This is by analogy to what the World Health Organization has set forth: HPV vaccination, cervical screening and treatment, and then treatment of cancer. And you can see, and many of you already know, that essentially you want to vaccinate before people get infected or exposed. And then you have this decade-long period before you see peaks in the population of precancer. That varies by sexual initiation in different populations in the United States and elsewhere. This sort of graph represents the United States. There are different country-specific graphs. And then you see the peak of invasive cancer around 45 years of age. The point here being that there's 25 years between the peaks of infection and cancer, which is why, for those people who don't pay attention to this area, that we have such a long time that we will be waiting to see an impact of vaccine on cancer, and why we need to have cervical screening for decades to come for all of the people who were ineligible by age to get vaccinated. We are conducting, as the Centers for Disease Control and others are, surveillance for the proportion who participate and get followed up, the proportion who receive treatment, the proportion who are vaccinated, and then we're looking at the outcomes like slides that I showed you just a minute ago. So secondary prevention has been focusing on innovations also. Over the several decades that I've been involved in this, we have moved from efficiencies in screening and triage tests and methods, but we really have not focused for a long time on population screening coverage and not on underscreening or overscreening. We've moved from PAP tests to co-tests using both HPV and PAP, and now we have recommendations for HPV alone screening. We have made further innovations such as genotyping, which have varied risks, P16 and Ki67 dual immunostaining, methylation, sequence variants to distinguish risks. And we've moved also to the delivery of cervical screening tests by self-sampling in terms of smaller randomized clinical trials, large by most thoughts. And we're trying to extend the reach of self-sampling to get to other populations that are not coming in to the clinic. But we have to remember this is not yet approved in the US, and it must consider any harms from losses in overall health benefits obtained through provider encounters. And for actually diagnosis, we have been working on improving the sensitivity of colposcopy and biomarkers to predict risk. Like people know the use of P16. I'm not a big fan of that, but definitely it has wide usage in pathology departments. I'm just showing you this not so that you can read it, but look at what clinicians are now faced with when they're trying to follow a woman, because now she has not just a positive or negative result, she has different genotypes, etc. Each of the outcomes have different risk. And it's become complicated enough that a computer cell phone-based application has been generated to help clinicians. So with all of these innovations, the simplicity of what a pap smear was in terms of management has gotten a lot more complicated, which means it's difficult to manage. So if you look at failures in cervix cancer screening, you can see we have the 3 kinds of testing, and the main failures are in red here: under-screening and non-participation, screening less often than recommended. Screening only protects you for so long. There's delayed follow-up or no follow-up, delayed or no treatment, and delayed or no surveillance. So I mentioned earlier that age or older age was associated with cervical cancer outcomes. Look at this graph from New Mexico, and it's been seen elsewhere, is that when women become older, they're not followed as often for abnormal cytology. This is also not meant for you to read, but quickly saying, here's a laundry list of screening and management follow-up failures, both at the woman, provider, and in cases of intervention system level. There's a lot shared in this disease between barriers to screening and to management. Those include a lack of information, a lack of communication, older age, practical and financial barriers, not enough money, no childcare, can't get off work, clinic isn't open, language, fear of the exam, fear of colposcopy. Sorry, I should see if I can go back, but maybe not. Let's see. Can you guys still see what I'm doing here?
Yeah, yes, we can.
Okay, thank you. But really what's important here is that we need some major interventions to our problem. These are not newly known. I would propose that television is going to need to be taken on as a means of informing the population. Social media, things that are in a big way done nationally and on state basis, because we're not making the impact that we need. And we need these things to be provided for no cost. We need multilingual health workers, and we need to make interventions at the population and community level. And I would propose to you at the system level, one of the things we need is electronic surveillance. So invasive cervical cancer is of the unscreened and underscreened. And this is a slide that, although it represents New Mexico, the data are similar, even if you're looking in a integrated health system. 65%, 64% of women who get this cancer were not screened or had inadequate tests. In Kaiser, many years ago, I can't even remember, but the early 2000s, there was a report that says that 56% of women who are insured attending Kaiser were similarly not screened or underscreened. Older age pops up again, with women with more advanced cancers being less likely to have been screened. And if they were screened, they were more likely to have a false negative. We have a growing problem with adenocarcinomas, where the anatomic situation is that the distribution is that the squamocolumnar junction moves up into the canal as women age, and so sampling is harder. Only 32% of all cervical cancers were screen detected, and only 9% in our population, up to 15% in other populations, did not get follow-up with biopsy. So I'd like to begin closing by saying that we need to take some bold action here. We have to look at future research out of the box that we've been looking at. We need to scale up the interventions to population and community levels. We need to do that like we have done somewhat for vaccination. We can't just make posters and only have these things happening in very microcosmic ways locally. We need to think big. We need to implement bold interventions to screen and follow up underserved groups by overcoming barriers of race, language, poverty, and geography. And we need to embrace innovative models of service delivery. I don't know how many of you go to providers who tell you you need to get a gynecologist in order to get gynecologic care. So to deliver screening, we need to have non-traditional providers doing this. An internist need to be able to deliver pap smears, and self-sampling needs to probably be seen as something that we could do in the community, at Costco, at Walmart, at Target, in mobile units, and in community pop-ups. We need to build information systems so that a woman's healthcare information isn't buried wherever she went, either in paper or electronically. These systems need to transcend healthcare so that it is beyond systems, providers, and patients, or where or who is paying for your screening and pre-cancer treatment. So I'm almost to the end here, and I wanted to just say, I felt like saying the elephant in the room here is that we don't have a healthcare delivery system. We don't have an order, an integration, or an accountability that exists in our country. And that creates the significant barriers to deliver equitable healthcare. I mean, we can't go on and say that this is not really our main barrier, and that we expect that poor and other special populations rely on getting their care from, even for cervical cancer prevention, from governmental public health agencies, and they are severely inadequately resourced. And we've got to do something about this. Finally, the incremental benefits from continued investments in current prevention research that is core in innovation will not probably address equity, and that we need to change our way that we're extramural funding programs are developed, and think about from the bottom up how we can work with our extramural investigators for input how to do that. So in closing, this is a lot that we all know, and the posters exist and the ideas exist, but we're not putting it to work. We've got to do more. And I wanted to thank Dr. Temkin, the Office of Research on Women's Health, and my support, which is through the New Mexico HPV Pap Registry Steering Committee. Thank you.